it's a bigger topic because we're gonna have to cover type 1, type 2 diabetes, a little bit on gestational, like one slide, which you probably talked about a bit in your OB course. So we'll just kind of refresh again. Nothing ever really goes away in nursing school, right? And I always kind of come back and revisit certain topics. So very briefly, this is kind of how I chunked it up. We're going to talk about your normal function of glucose and metabolism, and go over that with you. Get that in your head so that all the other pieces, when there's something wrong with this system, you're able to kind of work through how this is going to look with your patient. So we need to talk about type 1, type 2, gestational, and there's an other category. Has anybody heard like mixed diabetes or other terms? Like everybody's making up something now. Because there's variations to it, and it's not a one size fits all. Everybody's diabetes acts differently. So we're going to get into all that. Another big section is the care and treatment. This is where pharmacology is going to get big. There's a whole bunch of new drugs, or they've been out for a while. New to me from my adult time, I only had a few oral diabetics. Now there's a whole bunch. So we're going to talk a lot about the oral anti-diabetic medications, and we'll obviously talk about insulin. And you guys have been working with it in clinical, so you're probably pretty familiar with this. So we're going to get your brain wrapped around it a little bit more, maybe make more sense. Maybe look at it in a big picture sense, but you should be giving insulin, and you should have already been looking that up. But let's put it all together and compare side by side with all the different types. So there's a lot there. And then the last bit, we'll talk about the complications of diabetes and some of our nursing responsibilities. A lot of you have been already dealing with that in clinical. So this might be something that is a good review for you, maybe a little bit more detail for what you know, but hopefully, I think the hardest part, just personal opinion, would probably be the pharmacology piece, just because there's so much. So we're going to break it down, we're going to look at it by class, and we'll talk through it. So if you have your pathophysiology down and you understand how these hormones work, this is an endocrine-based disorder. So we need to talk about endocrine and hormones and how that's working in the body. Once you get that solid, it's probably going to make a lot more sense when you look at pharmacology and all these other pieces to it. So far so good? All right. How's everybody feeling about diabetes? Who's feeling like you're pretty comfortable with it? You've worked a lot with it in clinical, or you're great in your job? Or you're like, I just know when the sugar's high, I gotta get insulin. That's okay. All right. I was like, we have no time for games this morning because this is a big, I've got 101 slides in here, so we're gonna go through, right? So I like the Kahoot to kind of test your knowledge and see where you are, so I know how much detail we need to give you. So raise your hand if we need to have a conversation in between. We're going too fast, too slow. Let me know. I start seeing you nod off, we'll go faster. All right. Okay, a little bit on, we talk about statistics because this is a big thing, right? We have, it's a chronic disease, multi-system disease, characterized by hyperglycemia. It has to do with some abnormality with insulin, right? Got something going on there. Where does insulin come from? The pancreas, right? Okay, so we're going to talk about that too. 38.4 million, and I like this in percentages because then you have to know, well, what is our population? How big is that? 11.6% of the US population in total have either diagnosed or undiagnosed diabetes. What's alarming here is that undiagnosed, like 22.8% of adults with diabetes are undiagnosed, walking around, maybe have an idea, maybe they don't know. Then we have pre-diabetes. That's kind of new in the last decade or so. We're talking more about pre-diabetes. People are diagnosed as pre-diabetic, which really is just more like a warning sign for them to take action, right? 97.6 million adults older than 18, 38% of the population are pre-diabetic, or considered pre-diabetic. And then of our older population, that's even more so. Almost half the population over age 65 are pre-diabetic. So they've got the warning signs there. They've got, everything's pointed in the direction that if they don't make any lifestyle changes, dietary changes, then they're probably going to face some diabetes at some point. And it is the 7th leading cause of death. So pretty big deal. You hear about it all the time. The patient's not even there for diabetes, they're for something else, but they're also diabetic. And they have heart disease, and they have hypertension, and they have, and, right? all the things. So this is one of the big things that's probably causing all of those other little things that go along, all those comorbidities that you're putting on your little Simchart care plans. Big deal. It's a leading cause of adult blindness, leading cause of end-stage renal disease. Maybe you work on a nephrology unit or had a clinical nephrology. Are they all diabetics, pretty much? A good portion of them. Non-traumatic lower limb amputations, so meaning wasn't a vehicle accident or some kind of explosion. Most of our limb amputations are either from primarily from diabetes. Some are from other, like pediatric cancers or things like that. Major contributing factor to heart disease, stroke, hypertension, high cholesterol, and you'll understand why pretty shortly here. So we can't talk about that and talk about when Oklahoma ends up being close to number 1 or maybe 42nd in the nation for the prevalence, like the 42nd highest. I forget. This is from OSDH. So I like showing this for you because a lot of you aren't thinking about public health necessarily. We do tend to focus on the acute care setting, especially with clinical, but public health is a big deal. That's population health. And so we have a lot of diabetic educators, nurses working in the health departments to help with these chronic illnesses that we have in Oklahoma. Diabetes is one of our biggest ones. So in this graph here, I'm showing you the southeast area. It's almost like the top for all the things. All the bad things that we have a reputation for in Oklahoma, all are happening in that poor southeast. Drug, suicide, all those statistics are in that area. It's very rural. We have a lot of Native Americans in that area too, and a community that's got poor access to health, which there's a lot of improvement going on right now. We're trying to get there, but that's probably what's pointing to a lot of these issues. So of course diabetes is on that list. Yeah. You want to split it up and look by education. These graphs are pretty interesting. If you're really interested in this in population health, you can go to OSDH has all kinds of graphs and reports. Sometimes there's current information, sometimes not so, but this is a big topic, so we've got some current stats here. But you can look at by the disparities and the social determinants of health. That's a big public health phrase that we look at. So if you're less educated, you might have a higher prevalence of diabetes, your income, lower income. And if you think about the situation that people are in and where they live and the access to food that they might have, we've got a big food desert in this northeast side of Oklahoma City. Like in that whole capital area, think about where's there a grocery store nearby there, right? What do they have? They have Brahms and they have the gas station. Not a lot of access to fresh foods and healthy foods. So all of these things are things you probably want to think about before we start judging our patient for their lifestyle choices, because this is the type 2 has a lot to do with lifestyle. But some people really don't have much choice in their lifestyle based on their social determinants of health and where they live. So we want to make sure that we're not already putting a bias when we walk in the room and we're taking care of a patient with blood sugars out of control. So we want to be empathetic about what's going on, right? Okay, that's why I show this, because it has to do with your care. Even if you're not in population health, it's really important to understand what you're walking into when you get into that room and not judging your patient based on their disease process, right? Okay. All right, so let's get to that pathophys piece of it, that glucose metabolism. All right, so we're talking about glucose in particular, insulin, glucagon, the liver, and the pancreas. All these guys come together to handle this sugar. You guys remember any of this from maybe anatomy and physiology? Okay, good. Sometimes it's a refresher. The glucose, glucagon, glycogen. What are we talking about, right? All right. So sugar is the main deal here. We're talking about sugar. We use it for energy. Our cells need it, right? So we're talking about fluid and electrolyte balance, elements entering and exiting cells. We're talking about glucose too, doing a similar thing in and out of a cell. So, and when we're eating, obviously our food gives us sugar and it gets into our bloodstream and we use it up, right? Usually your brain and your liver are the first to use it so it can function, right? And excess stores, your muscles will then use the sugar from the food that you eat, and then, the leftover gets stored back into the liver, right? So, and then it's stored there as glycogen. That's the form it's in when it's in storage. So, when we have excess at insulin, or when we have sugar in our blood and we need it for our energy, insulin's gonna go in and it's like the key. It opens the door to allow that sugar into that cell, okay? So think of insulin as the gatekeeper, all right? It's coming from the pancreas, all right? So it's secreted in those beta cells. We have alpha cells and beta cells, right? The beta cells in the pancreas, in that islet of Langerhans, some German guy, I think, maybe, named it after himself, but those are the inside pancreas, that's where that insulin production comes from, in those beta cells. So you get super microscopic there, but that's important to know, beta cells, because some of our medications are gonna work on those beta cells that cause us to increase more insulin production, okay? So that's gonna come up later. So it's our gate, opens the door to let that glucose in the cell. So I think if we look at this way, pancreas senses we've got a lot of sugar floating around, and so it's gonna send this insulin out and say, oh, we need to put it in the cell, and it's also gonna tell the liver to store the excess, this glycogen, okay? So it's inhibiting that gluconeogenesis. So it tells the liver, slow down, stop sending sugar out, we got too much, start storing some stuff, right? Enhances fat deposition, increases protein synthesis for energy as well, so we use both. So insulin does a lot, but its primary goal is that gate. Open the door, let the sugar in the cell, okay? So then glucagon is secreted by the pancreas to convert that stored glycogen back into glucose when our sugar is dropped. So we stopped eating and we don't have any excess floating around in our bloodstream. It's like, uh-oh, we're hungry. We're gonna need a little bit until we can get to our food, so we're gonna have to have that liver send some sugar back out because we put it in there to store for a little while, right? So now we have to open that gate back up, let some of that glucose back out into the bloodstream and bring our blood sugar back up. So in this picture here, pancreas is sending glucagon into the liver to take that glycogen, make it back into glucose, and put it back out in the bloodstream. Okay? Review? Or is this new? New review. It's been a while, right? It's been a while. Does that make sense? You got glucose, glycogen, which is stored, and glucagon, which makes sugar gone from the liver. I don't know if you think I was still remember that. Okay. Glucagon, it kind of takes, I'm an 80s kid, so it makes me think of like Decepticons. Maybe the Transformers, glucagon gets in there, and hey, I don't know. Okay. However you guys think of the ways that you remember these things, there's my funny brain working for you. Okay. Normal insulin secretion, so this is a little graph. Anybody ever chart their blood sugar or seen somebody's graph of blood sugar and how it peaks or spikes and how it levels out? Or anybody work with somebody who's a type 1 diabetic who's watching the continuous glucose monitors? No? Okay. This is kind of what that would look like. So if you had one, have you heard of those? CGMs, the continuous glucose monitors, instead of finger pricking, we'll talk about them too. But it's like a catheter in your subcutaneous tissue, and it can track over time a continuous estimated blood sugar, and it gives you these little waves when you have peaks and plateaus of insulin. So insulin in the blood, you have food, you increase that blood sugar, your pancreas says, oh, there's sugar, we need insulin to come in to let the cells have it so they can use it for energy. And it spikes higher in the morning, and then this is also the body's prepared for that. We kind of start out a little bit high in the morning. Or we plateau out as a diabetic, they usually start high, so they tend to spike a lot higher in the morning, but we'll have a good peak there and prep for the rest of the day, right? So it's important what you eat in the morning too, like having like sugary cereals and your Lucky Charms for breakfast is really gonna spike your insulin pretty high. So throughout the day, you're using up that blood glucose, insulin's backing off a little bit, you have lunch, you have another little peak, and it's gonna dip down, unless you're somebody who's eating, snacking throughout the day, you're gonna have your insulin go up and down, right? And of course, we're kind of fasting over the night, unless you work night shift, or you're up all night studying. You're constantly spiking, and that's important. I'm gonna talk about that in a minute. This up and down of your insulin, your blood sugar, can cause problems for you if you keep doing that over time. Okay, so talked a little bit about the glucagon here, but there's some other hormones that also do some counter-regulatory hormones that act when our blood sugar is low, so it kind of has that opposite effect. So it opposes insulin, it stimulates glucose production and release by the liver, epinephrine, growth hormone, and cortisol. Cortisol's a big one too. So times of stress. So it's stimulating more glucose at that point too. So, or if you're on corticosteroids, this is why we're gonna have increased blood sugars. Okay. So it's supposed to help balance. You know, it's all about homeostasis. But if you've already got heightened blood sugar and then you've got excess cortisol, it's gonna heighten that blood sugar a little bit more. So it's trying to counteract, but it's not really paying attention to insulin if you've got some of these problems like diabetes. So it's extra hard for them. So metabolic syndrome, we're gonna talk about two things here. Before the diagnosis of diabetes, we have pre-diabetes and we have this metabolic syndrome that can happen. Really, pre-diabetes probably should be the slide before this one, but metabolic syndrome is really just a cluster of symptoms. So it's like having pre-diabetes and some other health risks at the same time, right? So at least 3 of these 5 factors. So fasting glucose. So if you were to sleep all night, or at least go for a good 8 to 12 hours without eating, and you check your blood sugar first thing in the morning before you have breakfast, that is a good fasting glucose. And if you're above 100, that's one of those suspicious risk factors, okay? It could be a sign of prediabetes, but usually we're a little bit higher than that, but that's a sign right there, okay? Abdominal obesity, so we can do an abdominal circumference, and if we have excess weight, that momentum, extra fat storage in that area, that puts us at higher risk for diabetes later, and puts you into this metabolic syndrome category. Hypertension. Now it says 130, equal to or greater than 130 over equal to or greater than 85. It's probably a little bit lower than that because we've lowered that threshold with hypertension. That somebody in their 120 systolic is considered like pre-hypertensive. So if they're kind of living in that area and they have 2 of these other factors, they may still consider them in that metabolic syndrome state. So greater than 40 inches for men and greater than 35 inches for women. Not pregnant women. Maybe talk about that recently. And the triglycerides, right? So greater than 150 in your triglycerides, so they'd be on the high range there. And then a low HDL, so those are those healthy lipids. Less than 40 in men and less than 50 in women on those. So we want that number to be higher. We want our LDL to be lower. So pre-diabetes, it's usually asymptomatic. So somebody doesn't know that that's probably why that statistic is so high, that pre-diabetic, most Americans are walking around pre-diabetic and don't realize it because they're asymptomatic. The only way to really know is to start monitoring your blood sugar, or really to look at your hemoglobin A1C. So have you all heard about the hemoglobin A1C, seen it? Maybe your patients had it drawn while they're in the hospital, maybe they're there with an infection and they just kind of want to see if their diabetes is not managed well. But it's not a one-size-fits-all with, we don't just look at hemoglobin A1C when it comes to diagnosing somebody for diabetes, or even pre-diabetes. We're supposed to look at the whole picture here. Because hemoglobin A1C, even though it's like a snapshot, an average of what their blood sugar has been for the last 3 months, we don't know how long they've been peaked or how often they peak with their insulin and their blood sugar up and down. That matters too, because that can adjust that particular number. So we really want to kind of look at a whole picture, or how they've been trending, how long have they been in these hyperglycemic state or hypoglycemic state, because that could play into that number. So below 5.7 is normal, that's the goal, we'd like to be there, but if you're between 5.7 and 6.5%, then you're considered pre-diabetic. So 6.5 is that threshold for diabetes. So like I said, we don't just look at the A1C, they can do this impaired glucose tolerance test. It's a 2-hour glucose test, and then if you fail it, it's because you're 140 to about 200, 199. fasting glucose, 100 to 125, and then hemoglobin A1C in that yellow zone. So this is important because how long has somebody been in this pre-diabetic state? Right? That's something we might want to know. Do they know? We don't know. If they've been asymptomatic and they haven't really known, they just happen to come in, decide it's time to start get some annual checkups done. They haven't been to the doctors in 5 years. We really don't know how long they've been in that state. We could look at their lifestyle and how things were, if they've been gaining weight, about when has that happened, and we can kind of estimate, but they estimate about 10 years from onset of that prediabetes is about when they then have the full-blown diabetes. But again, if we don't know, it could have been like them living that way for a while, so we really need to start watching them and helping them get back to health. So again, I just talked about that. The past 2 or 3 months, it's about an estimate. It gives you an idea if their blood sugars have been in range. My next slide will show you a little graph so you can kind of see what that looks like. It's used to diagnose, monitor, and response to therapy too. So if we've decided, diet and exercise isn't enough on its own, and we're going to start some oral medications, we can monitor their A1C to see the effectiveness of their treatment. Again, it's not a one-size-fits-all thing. We need to look at the whole picture, but it helps us to kind of gauge where they are. So it's easy for providers to kind of get stuck on that A1C. Working at Baptist in the PICU, we get type 1 diabetics, we'll talk about that too, but kids in diabetic ketoacidosis admitted to the intensive care unit, and a lot of them, not DeGoy, I'm trying to think of his name, one of our endocrinologists would give like a $20 bill to every kid who had his or her A1C like less than 7. They gave right there in the office, $20 bill. So one of his patients was one of my old Girl Scouts. She ended up diagnosed like one summer, it was like right before summer camp, and so she missed out on summer camp. But that's how I found out about it. I'm like, well, I'm gonna have to tell them, because I worked night shift, I didn't see him very often, but I'd have his patients. I'm like, you're paying, how much money are you losing on this? He must be a really good doctor. So they're motivated to do well, but use bribery to get these kids to kind of take care of themselves. $20 for their A1C, but he just used that number as that scale. So it's like, just because what if this kid didn't have their A1C right, but they're doing the other, maybe they had an illness, or maybe there was a lot of stress in their life and they couldn't really get that A1C in the right range, they were kind of punished for it. So like, that's a little not fair. But all that to say, it's not, we don't want to focus too hard on just that one number. We want to look at the whole picture. Okay, so this graph will show you, just going to give you a little understanding, what does it really mean? What does 6.5% mean? It means that on average, their fasting blood sugar is probably averaged about 126, just fasting. So after meals, it could be spiked. So this is no glucose or no food in the last several hours. So prediabetes means they're hovering above 100 on a fasting glucose. Do you know where we should be if we're fasting? What that number should look like? You guys learned that in FU1. Remember that? When you guys learned how to do finger sticks?
Is it under 100?
Say what?
Under 100?
Under 100, yeah. How low's too low?
60.
Below 60, 70? So we want them to be 70 to 100. Usually they're about 80 to 100. We might be concerned. So think about the patient who has a really high A1C. They're probably used to having their blood sugars like in the upper 100s, 200s, 300s. Especially if their A1C is way high, like a 9, right, way up there. And then now you see them at a 70 or a 90, or heck, even like 110. You're like, oh, that's pretty good for a diabetic, right? Not if you've been up in the hundreds and you're used to being up there. That could be a severe drop for them. So again, big picture, can't just look at the numbers. But it kind of gives you an idea what their average, we're talking about fasting blood sugar. So everybody in this room, if you were to go all night without eating, wake up in the morning, check your blood sugar, you should be below 100. So 99 or lower, obviously not too low. That means your body is able to metabolize sugar appropriately. Okay? So we want to catch people in this stage. We don't want people to be pre-diabetic, But if we capture it, we can help them, because the treatment for it is lifestyle, diet, exercise, right? We want to screen them. We're checking hemoglobin A1C. They don't need to start doing finger sticks. I mean, they can if they want to, but, you know, diet and exercise is gonna take a while to kind of see how that's trending. Again, until they get into routines and habits for this new lifestyle change. So they don't necessarily need to be finger sticking frequently. We'll just monitor their A1C over time. You know, they might not need a whole doctor visit, but they might just come into the lab and get it checked, and so that we can monitor and watch that. They need to learn what those risk factors are and manage them. We're watching for those symptoms of diabetes, so we're gonna talk about that in a little bit. And of course, that maintain healthy diet and exercise. So this education, this is hard. People are used to a lifestyle, or again, some people have no choice because they live in a food desert, or they, you know, have other or genetic factors that play, and they've been trying, but it's not working, right? All right, so that's the pre-diabetic. What are the types? As you all know, there's type 1, so we'll talk about that first. This used to be juvenile diabetes. We have adults with type 1 diabetes. Basically what it is insulin dependence. So it doesn't usually start out that way where they all of a sudden don't make any insulin. It's kind of like a period of time where there's no production of insulin. They might have a little bit of insulin coming into their system, and then there's no insulin. It takes a little while for them to be completely absent of insulin, but that's usually what happens. About a year into the disease, there's no production. It accounts for like about 5 to 10% of all people with diabetes, so not as common as type 2. Generally affects people under age 40, but my brother-in-law got it mid-40s. We'll talk about how this can happen, but for him, we think it was pancreatitis. He had some viral infection that damaged those beta cells in the pancreas and threw him into type 1. So it can happen at any age. So it requires exogenous insulin. So insulin that's not coming from your body, because your body produces insulin, but we're gonna need outside sources, so that's what that means. And they need it for survival. So type 2 diabetic might be in a different situation. Other things are gonna be what may end their life, but this not having any insulin will cause coma if they get to the point where the sugar's too high. So they need it for survival. And this remission piece, that 3 to 12 month remission, that's what it's talking about. So early on, it's like their pancreas is starting to shut down, so sometimes it's making insulin, sometimes it's not. It's really difficult to manage type 1 diabetes during that honeymoon phase, because you're giving them treatment, you're giving insulin, they require it, and all of a sudden their body decides, oh, I'm gonna throw a little insulin in here too, and now what happens to their blood sugar? Plummets, it goes down, because remember, insulin's processing that sugar, so insulin's goal is to use that sugar to get rid of it, right? So it's gonna drop. So we need to make sure that those type 1 diabetics who are newly diagnosed are really watching their sugars really closely, because during treatment they can plummet. So they have to know hypoglycemic signs and symptoms so they can interact real quickly and make sure that they don't pass out, have an injury. Okay, so this is an autoimmune disorder, primarily. So the body is attacking those pancreatic beta cells. So it creates those antibodies, goes in and attacks it. Now those beta cells can't produce that insulin. And there is a genetic link in type 1. So my Girl Scout, I used to lead Girl Scouts, I don't anymore, but one of my Girl Scouts, her dad also had it. So, and they kind of suspected that his girls, they were both twins, might come down with it. One got it, the other one hasn't yet gotten it, but they are fraternal, they're not identical. But it is genetically linked, and sometimes it's not in immediate family. Sometimes it's an aunt or an uncle that might have type 1, and then niece or nephew might come down with it. Now type 2, there can be, I know I'm jumping the gun here, there can be a genetic link there, but just because somebody has type 2, I think a lot of families have a misunderstanding about that. They think that, grandma has type 2 diabetes, so that means like I could get it too. It's not necessarily like passed down solely genetically. There's other setup for you to then become a type 2 diabetic, but there's a stronger genetic link here with type 1. So, let's see. idiopathic diabetes inherited. So when they're not sure how they got it, it's usually, if there wasn't any particular reason, like a viral infection or specific damage to the pancreas, then they usually assume that it was a genetic link. We have a lot of kids come in with DKA during COVID time, so we didn't have a lot. I told you RSV was a big deal, right? RSV and all the other respiratory viruses except COVID for our infants. Our older teenagers, we had a lot of suicide ideation during COVID. That was another big admission. Diabetes was one for a short period of time too, type 1, new onset. And they were suspecting that because in kids, COVID was primarily a GI, causing GI inflammation for them. They think the COVID virus was attacking their pancreas and setting them into type 1. So, and some of these kids are still, it's not something that goes away. Those cells are damaged and they're still living with type 1 post-COVID. So I don't know how much publication that is. It's kind of fun fact for you. Not so fun fact, but thanks COVID, right? So that's what was happening to kids. We weren't seeing a lot of respiratory symptoms. We were seeing GI symptoms. They were getting the GI bug, flu, like the GI flu, stomach bug, which is an actual flu, but does that make sense though? Like they weren't presenting like the adults were with all the respiratory, they were getting diarrhea and all that. And so they had GI inflammation, and if it got to the pancreas, we saw some kids come down with type 1. Okay, so you guys heard of the 3 Ps? Polyuria, polydipsia, polyphagia. You can have these symptoms in type 2, but it's more often in type 1. Especially if you're talking about younger kids. Again, younger than age 40, we know it can happen at any age, but if you know a child or have a child that's all of a sudden tired all the time, needs to go to the bathroom, waking up at 2 a.m. super thirsty, crying for something to drink, and they're getting thinner. It's pretty rapid onset too, not something that happens over time. And it could, if it's not noticed, if there's subtle symptoms, they could, sometimes they go into the emergency, the diabetic ketoacidosis state, some metabolic acidosis, and those are the symptoms that we see. So we've seen that in the hospital. They brought them to the ER because they were having all this Kussmaul breathing, this rapid breathing. They didn't know what was wrong, they didn't know if they were sick. They were vomiting, they just thought it was a really bad stomach bug, and they were super weak. They bring them to the hospital, and we check their sugar through the roof, and we do some more labs, and we find they're in ketoacidosis. So they get admitted for that. That's something you probably would talk about in NP4 a little bit more, because that's emergency critical care type stuff. But sometimes that is when the signs and symptoms are noticed for someone with type 1. These other polyuria, polydipsia, and polyphagia weren't really that strong to notice and recognize it. But sudden weight loss and weakness and fatigue, it's not just the 3 Ps. So they have the weight loss along with it. So this is when like the aunt or uncle, I think of that, a video I got for you, talks about how like a family member, the mom was curious or like worried about their kid, and this aunt has diabetes, and she's like, yep, that's what happened to me too. Get her checked out. All right. So I think this is that video, maybe.
I don't really remember what our family was like before diabetes. It's just always there.
I was diagnosed when I was 2.
I picked her up one afternoon. The teacher commented that Molly sure was cranky and cried a lot today. And she said she was thirsty. Did I think she had diabetes? I didn't even know what diabetes was. It didn't occur to me. I called Molly's godmother, who actually happens to be a type 1 diabetic herself. And she said, and I quote, "Run, don't walk to the doctor. Molly has diabetes." It was devastating. We immediately went to Children's Healthcare of Atlanta and received 2 days of training in reading food labels, meal planning, how to count carbohydrates when you're out at a restaurant. How do you go about, counting carbohydrates and so forth. So the diabetes educators at Children's Healthcare of Atlanta were just really amazing resources for us because we knew nothing.
Tap, 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 tap. When I wake up, I check my blood. Before I go to school, I usually check my blood. Or before we have snack, I check my blood. At the end of the day, I check my blood again. And I do a shot every night. It's just kind of a part of my life now.
I mourn the loss of spontaneity, the ability to run out to the ice cream truck, because you gotta check your blood sugar. Molly, if it's too high, you can't run out to the ice cream truck, or you can go get an ice cream, but you have to save it for later till we bring your blood sugar back into a normal range.
If my brother just goes to get something to eat and like a cookie or something, I'm just like, can I have one? And no, you can't.
Clap, move, over.
Oftentimes you hear diabetes and you think, oh, this person must need to lose weight. A little exercise, perhaps some oral medication, or my daughter, for instance, she'll outgrow it. So there's a lot of misconception about this disease out there.
We have to give Molly additional insulin.
For her though, it's life and death.
Heart failure, loss of vision. Ultimately, you could have circulatory issues and lose a limb.
Managing her diabetes before school.
It was time for her first shot by myself. I'll never forget it. She was 2 and she was running away from me and, of course, scared for her life. And I picked her up and I put my leg up on the kitchen counter and I threw her over my leg so that I could shove a syringe. And that's just counter to anything that mother's instinct tells you, that you have to put your child through that. And it was going to be multiple times each day, every day, until when? Until there's a cure. So that was the punch in the gut.
Sometimes I think about like what my life would be like without diabetes. And so that makes me really want to find a cure.
That's where we are today, striving to find the pot of gold at the end of the rainbow, which is a cure for diabetes. And we're still trying to find that rainbow.
She's an inspiration to me. She's an inspiration to kids her age. She handles it beautifully with grace.
I keep showing you guys some sad videos. I just have to cry in there. But really, I wanted you to just see how it's a grieving process in the beginning, and then you just learn to live with it. And there's a lot of other videos out there too, and a lot of them are like, families talk about how like now they don't know what life is like without it. Or there's an adult that had a video out there talking about, she's planning for a wedding, and all she's worried about is what her sugars are going to do that day, because you just never know. You can do your best and try, and it just controls your life. So like when I was talking about cystic fibrosis, how those kind of chronic diseases control these people's lives, and it's like they wish they could just not have to deal with it, and it wasn't a normal part of their life, and they kind of resent the disease process for it. But it just becomes a part of them. So it was just kind of cool to see the little girl talk about like, I don't know what it'd be like. And she's motivated. Maybe she'll go into healthcare and help find a cure. But they are working on that. But it's just good to see somebody else say it from their point of view and like what it's like for them. I keep bringing up the girl that I know that was in Girl Scouts with me, and she goes to another camp for diabetics, and it's a really good way, especially for teenagers, to interact with others that are like them, and see how it can be normal and talk to other kids who understand where they're coming from. So she goes to these camps. She's been begging me to come be the camp nurse, and it's like always when I have something going on, but I'm going to do it one of these days. I used to do summer camps for Girl Scouts, so but she does a lot of speak engagements. I was like, if she wasn't in school, I would try to get her to come here to talk to you all, but it would take up too much time too. But kids are getting involved like that. She's had photo shoots to kind of normalize her pump that she wears, so I'm really super proud of her and the leadership stuff that she's doing. So those are things that you can get involved with as well, like summer camps and for kids with diabetes or cancer. So there's all kinds of opportunities out there to help people who are living with these kind of diseases. Did I do this one? Okay, type 2. We gotta jump into type 2. All right, so you can tell my heart's somewhere with type 1. Pediatrics, right? All right, so formerly known as adult onset, because now we have some kids that are developing a type 2 like diabetes, right? non-insulin dependent diabetes, diabetes mellitus, that's what it was when I was in school, the NIDDM. So you can produce insulin. This can work in different ways. Either you're producing not enough insulin or you have insulin resistance. So there's different types, or some people have resistant insulin and then they're also not producing enough, or sometimes they do. So insulin is there, it just doesn't always work as well. So when we talk about insulin resistance, best way for me to explain that one is kind of like you're alcoholic. The more alcohol you drink, the more resistant you become to it and the more that you need to get the effect, right? Same with a drug addict. Your threshold of those opioids, you require higher and higher doses to get the achieved effect, the desired effect, than an initial dose, right? So if you abuse it, it requires a higher dose each time to get that high that somebody's seeking. Well, insulin is kind of doing the same thing. The more your body is spiking that insulin with those high blood sugar spikes, the more desensitized your body gets to that insulin, and the more insulin you require to have that response to get that gate open, allow that sugar into that cell. So that's what's happening with insulin resistance. So it's like a tolerance to insulin, okay? So I bring up that spiking, because remember that little graph I told you? So sometimes with insulin resistance, somebody's constantly exposed to these highs and lows rather than keeping their insulin in a nice steady state. Eating things with high fiber, slow absorption of that sugar, keeping those simple sugars down and not having cakes and cookies all the time. It's okay once in a while, but there's education that goes with diet, like you're pre-diabetic. You know, I don't want to tell anybody that they have to eliminate all fun things in their life or fruit, but if we pair it with things that help us slow down the absorption of sugar, like protein with carbs or fiber or whole fruit instead of broken down or cooked fruit, like apple pie, like have the apple instead of the apple pie, right? Because you have that fiber's not broken down, and fiber helps you digest sugar slower. So those are some things that we can help improve that insulin resistance with. We're gonna get to that again later, but that's what's going on. It's like those high sugar spikes and that insulin exposure starts to not be as effective over time. So risk factors: overweight, advanced age, family history, again, and some that could be lifestyle that we learned through our family. Childhood obesity and socioeconomic, so food desert type situations where all you really have are those high carb, high sugar type foods, processed foods that spike our glucose a lot. So symptoms can be similar to type 1 with the polyuria, polydipsia, polyphagia, but not usually. That's more the classic sign for type 1. Fatigue, recurrent infections too. So somebody might have all those risk factors, but they, like in women with yeast infections, if you think of like a high sugar environment, like those vaginal yeast infections, that yeast likes that sugar, so it allows them to grow more often. So yeast type infections can be pretty common in diabetes. Let's see, prolonged wound healing. You guys know that already, because you know if you have a patient in the hospital with some kind of wound or surgical wound, they're probably going to take a little longer to heal. So sometimes that's how we realize, wow, this wound really just isn't getting any better, and we start looking at maybe their A1C and their history, and start coming up with another diagnosis for them. Vision problems too in there, and that has to do with the sugar circulating, the damage it can do. So we talked about already, A1C level 6.5 or higher is just one of those indicators, right? We can do fasting plasma glucose greater than about higher than 125. That's what it's looking for. They can do the oral glucose tolerance test, and if they're over 200, that's another sign, diagnostic. They'll tend to repeat these type of labs just to make sure it wasn't kind of a one-off situation, or that there wasn't an error in the lab. We got to look at influencing factors. Did they actually eat? Were they really fasting for this test? You know, make sure we're checking all the boxes. And then hyperglycemic crisis or random plasma glucose. So random, whether they're fasting or not, that's greater than 200 is another one of those red flags. So you can probably think about goals. Obviously, we're gonna wanna reduce those symptoms, promote the well-being, we're gonna prevent complications, we're gonna talk about those complications, so if somebody is diagnosed with diabetes, that's gonna be a big priority for them. I mean, hopefully we don't get to those big chronic issues, that they manage their diabetes well, and we don't have to progress further in their treatment. They can usually stave off a lot of those complications in the end. Let's see, prevent or delay onset and progression of lung disease, that's what we were just talking about. Meeting goals of ABCs, diabetes lowers risk of heart attack. So A1C monitoring, BP, cholesterol, all those other things, because of those risk factors that result from having high glucose chronically. Here's your slide on gestational, so that we've talked about type 1, type 2, gestational a little bit, about 2 to 10% in the United States. Increases risk for cesarean, this I'll review. We're gonna screen them during their prenatal care. Let's see, onset of this is about 24 to 28 weeks gestation. It's gonna require some close monitoring. And then there's like a pretty high chance, or 63% chance can develop type 2 within 16 years. But usually, as soon as the baby's delivered, it's not an issue anymore. They're discharged from a diabetic educator. Okay, and then I mentioned a little bit about the other types. So if you have that B-cell injury in your pancreas, depending on what caused the injury and the issue and how it's functioning or not functioning, it can act like a type 2 where it's some insulin's being produced but not enough. So it depends on what's going on, but these people need to be watched really closely, and it's really difficult to manage these. It's kind of, in a way, easier when you know exactly what's working for somebody or exactly how the injury occurred, and then you can treat with the medications that can work in that process. But this can get tricky. But we've got kids that are we have some in the hospital, they come in with DKA, and we're like, well, they're new diagnosis. Not 100% sure it's exactly type 1, but yet they're not really looking like a type 2, so we kind of put them in this watch and see category. Okay, so care and treatment. This is a good place for a break. Do we want a quick 10-minute break?
Yeah.
It's like a little before 2. Let's go to 2 o'clock, right? 7 minutes, is that good? All right. I'll see you back here at 2, and we'll start talking about treatment.